Trauma, stress-related, and dissociative disorders is what we're going to talk about. This is chapter 16 in your book, and we're just going to get started here. When we think about trauma-related disorders, these are traumatic life events associated with a wide range of psychiatric and other medical disorders. Understanding of long-term effects of trauma expanded, and effective treatments are now available. However, people in need of treatment do not always get the care that they need. Trauma-informed care is a treatment framework that helps us recognize and respond to the effects of all types of trauma. If we are able to implement this in all healthcare settings, we can reduce the damaging effects of trauma. In this chapter, we're going to look at attachment disorders, which include reactive attachment disorder and disinhibited social engagement disorder. We'll look at post-traumatic stress disorder of children and adults. We'll look at acute stress disorder, adjustment disorders, and we'll finish off with dissociative disorders. And this might include dissociative amnesia, depersonalization or derealization disorder, and dissociative identity disorder. So attachment disorders are typically disorders of childhood who have problems with emotional attachments to others. Reactive attachment disorders have consistent pattern of inhibited, emotionally withdrawn behavior. They're unresponsive to caregivers' efforts to offer comfort in distress. The other one is disinhibited social engagement disorders, and children demonstrate no normal fear of strangers. They seemingly are unfazed by separation from their primary caregiver. These children tend to be overly friendly and are usually willing to go with someone they do not know. These are both very rare disorders, even in high-risk situations. Without treatment, attachment disorders may have lifelong consequences, including lack of trust or not feeling secure in friendships and partnerships. However, children tend to be naturally resilient and with support can learn to develop healthy relationships. Treatment always involves both the child and the caregiver in individual and family therapy. Post-traumatic stress disorder, when we're talking about children and adolescents, according to the U.S. Department of Veterans Affairs, approximately 15 to 43% of children and teens experience trauma. That 43% is so high. Of course, more girls than boys go on to develop PTSD, about 3 to 15% for girls and 1 to 6% for boys. Nearly 100% of children who witness their parents' murder or sexual assault will develop PTSD. Other alarming statistical relationship with PTSD are for children who are sexually abused. 90% will go on to have PTSD, exposed to a shooting at school, 77%, and those who see community violence in urban settings have about 35% chance of PTSD. Post-traumatic stress disorder is seen early as even preschool children. PTSD may manifest as reduction in play or play reflecting aspects of the trauma, self-blame, detachment, estrangement, loss of interest in significant activities, and you will see some mood changes, maybe sleep disturbances, hypervigilance, or even loss of concentration. So let's apply the nursing process, and we always start with assessment. The type of data collected depends on the setting, the severity of the presenting problem, and the availability of resources. Assessment will be an ongoing treatment throughout. A mental status examination will help provide information about the child's state of the time of the examination. Assessment should also include development of the child or adolescent, and this can be done utilizing the Denver Development Tool, which will test gross motor, fine motor, language, and social skills. Older children or adolescents may need a more tailored assessment. Abnormal findings in the developmental and mental status assessment may just be temporary. The nurse working with the parents may handle stress-related behaviors or minor aggressions. However, as young people, use of maladaptive behaviors over time, they become more vulnerable to developing other psychiatric disorders. So early intervention is essential to reducing further disability. When we think about our nursing analysis, this may include post-traumatic response, impaired caregiver-child attachment, or impaired adolescent development. Outcome identification are the goals that are set specifically for our patient and could include, again, improvement to those priorities, right? Improved response to trauma, improved caregiver attachment, improved adolescent development. Implementation is done in stages. So when we look at the stages, stage 1 is providing safety and stabilization. We'll create a safe space. We're stopping that self-destruction and providing education about trauma and its side effects. Stage 2 is reducing arousal and regulating emotion through symptom reduction and memory work. So this is where they're going to find comfort from others. They're tolerating the affect. They're integrating emotions and accepting ambivalence, improving attention, and decreasing those disassociations. And then in stage 3, this is when they can catch up on development and social skills and try to develop a value system. So interventions in this stage may include coping skills, supporting efforts to achieve socially appropriate goals, and facilitating development of healthy social support systems. Treatment strategies for the traumatized child are designed to modulate arousal so that the child is helped to stay within the window of tolerance. And when I say window of tolerance, this is a term that means a balance between sympathetic and parasympathetic arousal. Traumatized children have difficulty shifting their emotions to accommodate different environments and social contexts. These alternates between hyperarousal, meaning anxiety, fear, hyperactivity, and hypoarousal, withdrawn, isolation, numbness, they're going to alternate between those. So increasing the ability for that child to self-regulate through specific strategies will provide a nurturing, safe environment and a sense of well-being and competency. Interventions for the child with PTSD, you can see those listed there. It's an interactive process. We're going to establish that trust and safety, build that rapport, use developmentally appropriate language, art and play to promote expression of feelings. You can read those there. Those are lots of interventions that we can do for our child with PTSD. And then the last is evaluation when we finish up our nursing process, making sure treatment is effective. What does that look like? If treatment is effective, safety is ensured, anxiety is reduced, emotions are appropriate, they achieve normal developmental milestones, and they're able to seek out adults for nurture. Treatment modalities for PTSD in our child and adolescents include biological treatments, so pharmacotherapy, typically combined with EMDR therapy or CBT. These will target symptoms that comorbidities like ADHD and MDD. Psychological therapies, we can talk about CBT and EMDR. That's eye movement desensitization and reprocessing. It is an evidence-based therapy used to treat children and adults. It helps people process traumatic memories. People are encouraged to think about the traumatic event while also focusing on some other type of stimulation, such as eye movement, audio tones, or even tapping. EMDR may work through neurological and physiological changes that help process and integrate traumatic memories. So let's move into trauma-related disorders for our adult population, and that's going to include post-traumatic stress, acute stress, and adjustment disorders. So we'll start with post-traumatic stress disorder in adults. Examples of PTSD inducing events may include military. A lot of times that's where we hear about it. We can also talk about crime-related, natural disasters, or even human disasters, such as accidents, car accidents, things like that. PTSD symptoms can begin a month after exposure, but symptoms delayed of months or years is not really common. We talk about flashbacks, and that's re-experiencing the trauma, and this can be very terrifying for our patients. When the person recalls a traumatic memory, physiological reaction, sensation of terror in the stomach, heart palpitation, muscle tension can occur. The person often does not know where these sensations are coming from, and it usually attributes them to present circumstances, and the past becomes the present. A lot of times, avoidance of stimuli associated with the trauma, causing the individual to avoid talking about the event or avoiding activities, people, or places that arouse that memory of that trauma. Persistent symptoms of increased arousal can be evidenced by irritability, difficulty sleeping, difficulty concentrating. They're very hypervigilant and have an exaggerated response. And then they can have some alteration in mood, such as depression, negative appraisals, or lack of interest. They can have very difficulty with interpersonal, social, or occupational relationships because trust becomes a very common issue with our PTSD patients. So again, we're going to apply our nursing process. We're going to do assessment first, which is going to include screening tools, history of onset, frequency course, severity, level of distress, and degree of functional impairment are important in that initial screen if it's positive. After our comprehensive assessment, we can think about nursing analysis, and we can prioritize our findings. Again, always determining the level of anxiety as either mild, moderate, severe, or panic. Remember, I talked about all of these are going to have an underlying anxiety. The biggest analysis is just going to be that post-trauma response. So as we look at our outcomes or our goals, a general outcome for post-trauma response is simply an improved response to trauma. The staged model of treatment for trauma is essentially the same for adults as it was for children. Stage 1, again, is providing safety and stabilization, creating that safe space. Stage 2 is reducing the arousal and regulating emotions. And then stage 3 is that developmental skills catch-up, enhancing problem-solving skills, self-awareness with nurturing, social skills, things like that. And then lastly, we will evaluate our patient. We'll evaluate, do they recognize the symptoms as related to the trauma? Are they using learned strategies to help manage that anxiety? Are they having no more flashbacks? Are they sleeping adequately? Do they have a satisfying interpersonal relationship? Treatment modalities. The primary treatment for PTSD is trauma-focused psychotherapy. Some medications can be used for this condition. Antidepressants can help manage symptoms of depression and anxiety. SSRIs are our FDA-approved medications. Due to lack of evidence for efficacy and known adverse effects, atypical antipsychotics, as well as Celexa, Elavil, Topamax, and Lamictal, are not usually recommended for treatment of PTSD. Psychological therapy, again, we can talk about CBT. We can also talk about EMDR therapy for our adult population. All right, acute stress disorder. This is immediately after a highly traumatic event, which can cause anxiety or detachment. These symptoms persist for about 3 days or longer, but they do not last for more than a month. After a month, the stress response should be resolved. If it's not resolved, then it becomes PTSD. So remember, this is our acute stress, not our long-term chronic stress. To be diagnosed with acute stress disorder, the patient must display at least 8 of the following 14 symptoms, either during or after the traumatic event, and that is how it's diagnosed. Sometimes a subjective sense of numbing, derealization, which is a sense of unreality related to the environment. You can see all of those listed there. I won't read them. I will let you look over them, just knowing you have to have 8 of the 14 in order to be diagnosed with acute stress disorder. So we'll apply the nursing process here. As far as assessment, it's usually similar to that of PTSD. The difference is that the individual has recently experienced the trauma, and they may have more difficulty sharing their symptoms. They may also more likely experience derealization, which makes that person less secure in their environment. As far as nursing analysis, we can prioritize after the assessment, and it may include post-trauma response, impaired adaptation, and anxiety. Again, we're going to level which level they're at. Outcomes are going to correspond with the analysis, with the goal of reducing the response to stress, improving our adaptation, and decreasing our anxiety. As nurses, we need to establish a therapeutic relationship so we're able to assist with problem solving. These are implementation now of our interventions. We also want to connect persons to support. That could be family or friends. We need to educate about acute stress disorder, collaborate for coordination of care, ensure and maintain safety, and then monitor response and or adherence to treatment. And of course, we will evaluate our patients, and this evaluation, again, will look similar to PTSD. Treatment modalities for ASD include psychological therapies. Again, CBT, cognitive behavioral therapy, has been found to be effective in reducing the subsequent development of PTSD and those with acute stress disorder. Specialized protocols for EMDR therapy can also be utilized. All right, adjustment disorder is the next one we'll talk about. This is a milder, less specific version of ASD and PTSD. It's precipitated by a stressful event, usually including retirement, chronic illness, or maybe a breakup. May not be as severe, may not be considered traumatic. Adjustment disorders may be diagnosed immediately or within 3 months of exposure. Symptoms may include all forms of distress, guilt, depression, anxiety, and anger. Some of these feelings may be combined with other manifestations of distress, maybe some physical complaints, social withdrawal, impaired occupational function, or even academic decline. All right, as with stress disorders, dissociative disorders also occur after a significant adverse experience and trauma. The predominant response is a severe interruption of consciousness. Dissociation is an unconscious defense mechanism that protects the individual against overwhelming anxiety through an emotional separation. However, this separation results in disturbances in memory, consciousness, self-identity, and perception. And the 3 that were dissociative disorders we're going to focus on are dissociative amnesia, depersonalization, derealization disorder, and dissociative identity disorder. So dissociative disorders happen when they have really high stress, high anxiety, and it's really their body's way to shut down and escape the current situation. These disorders can actually disrupt, again, that consciousness with the environment they are experiencing. A lot of times it's protecting that patient from that overwhelming anxiety. We probably have experienced disassociation in our own lives. And the example that I can really come up with is you're driving down the road, maybe it's a path you're familiar with, right? You drive to school, you drive to home, you get home and you think, wow, I don't even remember any of my drive. How did I get here? So that's kind of an example of disassociation. It's not really associated with a traumatic event or stressful event, but unconsciously you kind of lose yourself, right? You don't have recollection of that drive home. So magnify that to a stressful event or a high anxiety event, things like that, and it's just kind of a simple example. So it's that mild, fleeting, dissociative experience common for all of us, right? We're on autopilot. However, pathological dissociation distinctly differs from autopilot. So let's talk about dissociative amnesia. This is the inability to recall important personal information after trauma or stress. A lot of times we see this with violence, whether that be head trauma, abuse, substance abuse, or even rape. Patients may struggle with telling you what happened because they have found a way to block it out. There is a subtype of dissociative amnesia called dissociative fugue. The patient, in quotes, travels to another place and they have no idea who they are. In this fugue state, they function adequately within this new identity, but they don't remember who they are during that time. I know this sounds confusing. It's just, if you can think of your amnesia patient, now put them in where they've traveled outside of their body, they don't remember who they are, they take on this new identity, now they're in this fugue state. This may take them a few weeks to a few months to remember their former identity and get back to their former life. What can be frustrating with these patients is they become very distrusting of others. If you can imagine, if you're not really sure who you are, you aren't going to trust others. That trust becomes a real difficult concern with building rapport with that patient. Depersonalization, derealization disorder are persistent or recurrent episodes. Depersonalization is you really become an observer of yourself rather than experiencing the environment on your own. You're watching yourself experience it. It's an uncomfortable feeling about your body or mental process, like you're going through the motions of life. Realization is focused on the outside world. So it's like the outside environment around you isn't real, that you're just going through the motions in this real, unreal, or distant type of a world. It may feel robotic to the patient, but it's the way the patient may disassociate from their anxiety. And the last one we'll talk about is dissociative identity. This is previously known as multiple personality. Dissociative identity disorder is the presence of two or more distinct personality states that recurrently take control of behavior. Each alternate personality, or alter, has its own pattern of perceiving, relating to, and thinking about how the self and the environment. One of the personalities is used to function on a daily basis, and the other helps protect them from the anxiety they are experiencing. Each alter is really complex and has its own memory and behaviors. So if you can think about movies, there was a movie called Split, and then the newer movie Glass. We do see that the individual in Glass has 23 different alters. That's usually very extreme. Normally we only see about 2. When someone experiences this in their life, it can be very damaging to relationships with their family and their friends because this other person they are becoming has their own agenda. Typically, cognitive distortions will include an insistence that the alters inhabit separate bodies and are unaffected by the actions of one another. So let's apply the nursing process. Assessment findings should include objective data from physical exams, maybe an EEG, imaging studies, and specific questions to identify dissociative symptoms. There are several scales or tools that are useful to assess dissociation. Assessing patients' ability to identify themselves really requires more than just asking them to state their names. We need to assess change in behavior, change in voice, change in dress. That's going to signal the presence of an alternate personality. Nurses should really consider asking the following when we're talking about memory assessment. Can the patient remember recent and past events? Remember, if they can't, they have disassociated. Is the patient's memory clear and complete, or is it partial and fuzzy? Is the patient aware of gaps in memory? Does the patient's memories place the self with a family, school, or occupation? Does the patient ever lose time or have blackouts? Does the patient find themselves in places with no idea how they got there? That's going to help that memory assessment. As nurses, we also need to gather history, especially if self-harm is present. Pertinent questions that can be asked are, have you ever found yourself wearing clothes you cannot remember buying, right? That could potentially be self-harm history because they aren't remembering. Have you ever had people you didn't know approach you as though they were old friends? Does your ability to engage in activities such as sports, tasks, mechanical work seem to change? Do you have memories about your childhood, right? That's your history. As far as mood, that may vary depending on the alter that is present. Impact on patient and family. The patient's memory loss interferes with normal relationships. Whenever lives are disrupted, patients may also have thoughts of suicide. As far as self-assessment, nurses are going to feel skepticism for these patients, and they may struggle to believe in the authenticity of the symptoms. Nurses may also feel very inadequate in therapeutically communicating with these patients because the different alters may require different therapeutic thoughts or communications. Some nurses may just be fascinated with the patient and get caught up in the intrigueness. So make sure we're being self-aware for this patient population. After thorough assessment, we can prioritize our findings. Some of the analysis noted may include disturbed personality identity, impaired role performance, and anxiety. Again, we're going to specify which level they're at. And then, of course, those outcomes are going to be based on the prioritizations and includes improved personal identity, improved role performance, and we're going to decrease anxiety. The setting and presenting problems influence the planning of nursing care. So we have a phase-oriented treatment model that is recommended. Phase 1 is establishing safety, stabilization, and symptom reduction. Phase 2 is confronting, working through, and integrating trauma and memories. And then phase 3 is integrating identity and rehabilitation. The nurse will most often encounter our patient in times of crisis, and phase 1 will go into effect. As far as implementation, it's going to include process of integration, interventions offering emotional presence, and then health teaching and promotion. Normalizing experiences by explaining symptoms, teaching grounding techniques. Grounding techniques bring that person's awareness back to noticing real things in the present moment. These techniques may include stomping one's foot on the ground, taking a shower, holding an ice cube, exercising, deep breathing, or even counting backwards. It's just grounding them. It's bringing them back to reality. Overall, treatment effectiveness for dissociative identity disorder is integration, coordinated functioning among alternate identities to promote optimal functioning. This occurs primarily through long-term psychotherapy. As far as treatment modalities, there are no specific medications for patients with dissociative disorders, but appropriate medications are often prescribed for the hyperarousal, the intrusive symptoms that accompany PTSD and dissociation. Psychological therapies may include CBT, psychodynamic psychotherapy, EMDR, exposure therapy. You see those written there. Somatic therapy, the goal is to safely disarm the pathological defense mechanism of disassociation and replace it with other resources, especially body awareness and even mindfulness. And that concludes chapter 16. If you have any questions, you can shoot me an email or we can chat about it in class. Thanks, guys.